Hello to those joining us. We're going to give it a moment to allow folks to come in, but we're very happy to see you here today. All lines are muted to prevent background noise, but certainly feel free to introduce yourself in the chat box, and we'll have a chance to hear from you through some polls and other prompts later in this webinar. So again, hello and welcome. Feel free to introduce yourselves. We'll get started in just a moment. And because we do often get questions about this, we will be sure to share the recording close after the end of this session, but we will be able to send slides immediately after if you are looking for those materials. So I know we'll have folks continue to join us, but for the sake of time, we can go ahead and get started. So again, hello and welcome to this webinar session on care mapping. We're really excited to feature this topic today, really focusing on it being a valuable tool for working with both older adult patients and family caregivers. This webinar is an activity of the National Center for Equitable Care for Elders. My name is Ariel and I'm the program manager of our center. And today's presentation will be facilitated by our wonderful subject matter expert and consultant, Dr. Lynn Hollerman. We'll hear more about Dr. Hollerman in just a moment. If you are not already familiar with our center, we encourage you to stay connected with us during and after this webinar. All of our social media links are on this slide that you'll get at the end of this session. We like to provide multiple forms of training and technical assistance to health centers, other community-based organizations across the country who are focused on caring for older adults. I love to plug the Health Center Resource Clearinghouse in any activity we have because it's such a great one-stop shop for information on a variety of health topics. You can see that in addition to COVID-19 information, there's new resources on monkeypox and other items. We encourage you to check that out if you are not already familiar. We are used to having things by Zoom at this point, but just reminding folks that all lines are muted to prevent background noise, but we would love to hear from you. So with the webinar setup, we have options for the Q&A box as well as the chat box. Feel free to send your questions or your comments there. Like I mentioned at the start, we will make the webinar recording available as well as the slide deck to all registrants. And we'd also really love to hear from you at the end of this session. You'll get a chance to fill out a short evaluation that really helps us to shape future activities and understand what type of topics you'd like to see in the future. So these are the learning objectives that were advertised for this session. I won't read them all, but you can get the sense of where we're trying to go in this hour. And I hope that you'll find it really useful. So that being said, we're going to turn it over to Dr. Hollerman, who, as I mentioned, is one of our consultants focused on palliative care, caregiving, and she has a lot of things she can say about her background, but we're really excited to learn from her today. So take it away, Dr. Hollerman.
Hello, and you can go to the next slide. I want to just thank everybody who's managed to get on to the webinar live. I know it's a very busy day for most of you, so I appreciate that, but also just welcome to those of you who are listening on the recording. I'm not really going to read through my bio sketch. I just want you to know just a little bit about myself, though, in terms of my my history of being a professional, being in the professional world as a palliative care doctor, and then also as myself as a family caregiver. So I've spent about 25 years working on, I'll say, the front lines of clinical care. First as a primary care provider with medically underserved populations, and then also at the VA Maryland healthcare system. And then I had a really lucky chance to pivot into palliative care in 2003-4 or so, and had a chance to develop palliative care programming for the VA Maryland Healthcare Center, ran a hospice unit, had a lot of interactions with nursing home care and consulting in their hospital network. And then in 2007, I was able, I sort of had the chops at that point to take a directorship role at Stony Brook University, where I developed palliative care programming for them, and I was part of the oncology division during the 13 years that I was there. And it was really there that I started sort of understanding just how important the sort of caregiver structures were in terms of really helping people through serious illness and things related to aging and getting into the hospital. And I found myself more and more just being a patient advocate. And that made me turn away from the bedside in terms of that advocacy, in terms of our local systems, state systems. And that eventually brought me to a health policy fellowship in DC, where I really had a chance to think of issues of caregiving on sort of a meta scale, and that eventually led me to the consulting position that I have with NCECE. So you can go to the next slide.
Just wanted to mention, Dr. Hollerman, I think that there's at least one person having a harder time hearing. So I can hear you, but I think if you want to, if you want to speak as loud as it makes sense for you, that would be.
Okay, I've moved. I hope you can hear me.
Perfect.
Okay, so next slide, please. Okay, so what are we really going to talk about today? We're going to sort of really dive into what actually a care map is and why I use it. I'm hoping you're going to leave the webinar feeling really jazzed to use this approach. And really by the end of the webinar, you should be able to do that pretty easily. We're going to discuss which patient populations are best served by care mapping. But really, we're talking about, for the purposes of this webinar, we're really talking about persons over age 65, although I really think it can be applied no matter how old you are. And then we're going to move into how you can use care mapping in clinical settings. And we're going to do two case studies that I'm going to take you through on how I've used this in my practice and also how it's impacted me in my role as a family caregiver myself. And then the question is there any research? Well, the short answer to this, and kind of the long answer also, is no. So I'm not going to be spending a whole lot of time on research, but if anybody has something that they'd like to share with us, that'd be great. Okay, next slide. Okay, we have a couple of poll questions. This is all anonymous, but it's really because it just helps me understand who's in the audience. So I'd appreciate if everybody could just check off who they are, and I'm just going to give you 1 sec to do that. It's not mandatory or anything. And Tiff, if you want to tally that, that'd be great. Okay. And if you're other, I'd be so curious to know. So if you want to put that in the chat box, that'd be great. And I'm so glad to see so many case managers and social workers on the call, because this is really your area. So I'm going to be also looking forward to your questions. Okay, next slide. And I'd be curious to know, is there anyone actually who's using care mapping in their practice currently, just yes or no? If you have a great tool that you're using, we're going to be talking about Atlas of Caregiving on this webinar, which is a program that's being featuring during the webinar. But if there's something else, just put it in. And if Tiff, you want to tally that? No, lots of no's. Okay, so goody. So that means I'm going to introduce you to this really super cool thing. Okay, next. Okay, now I'm really curious how all of you perceive yourselves. Just, are you yourself in a caregiver situation? And it's mainly just to kind of acknowledge that we're all really doing both. We might be professionals trying to use care mapping tools, but we're also very likely to be in a caregiver scenario ourselves of some sort, whether we realize it or not. So I'm just curious. And Tiff, whenever you're ready. Yeah, okay. So I see, some people are, about 20% of you are saying yes or in the past. That's not surprising. Okay, let's go to the next slide. So I'm not going to spend a ton of time on caregiver stats for the purposes of this talk, but if you're really interested in what's called unpaid family caregiving and a very nice report about that, you can go to the AARP and look through that report. I put the link at the bottom there. So if you want to sort of doom scroll through that report, you can do that on your own. For the purpose of this talk, what I just want you to notice about the graphic that they have is that all those thick arrows are kind of going up, which is sort of suggesting that a lot of us are entering in, as our population is aging, we're entering into these sort of caregiver relationships ourselves, and there's a chance that it's going to inform our clinical practice as well. There's a stat that came out by the Census Bureau. It's, dun dun dun. There are going to be a lot of people over 65 years, and by 2030, that's going to outnumber the amount of children. I'm not going to judge that one way or another, but I do think in terms of the medical system, I don't think the medical system has caught up to this shift in demographics, and a lot of the ways that we approach care have really not caught up with this change. And also the other comment I want to make about caregiving is caregiving is really is many things. So it's a term I'm using, but it can mean anything from doing some food shopping for someone, or picking up their meds, or driving them to an appointment, or just showing up for coffee, to extreme versions of it, taking care of the totality of a person in their personhood and their bodily needs, being with them. So the range is huge. So care mapping intersects across all these kinds of domains of caregiving. So when I talk about caregiving, it's really meant to be a very broad term, to mean a lot of things to a lot of individuals. Okay, so next slide. Okay, so what exactly is it? Let's dig in now. And what actually is a care map? In the simplest terms, it's a diagram or a drawing of a patient's caregiver network. It's not that much more complicated than that. And what it's trying to visually show is who is supporting them in this diagram, and how they're involved. So that's sort of the basic definition of a care map. Next slide. Okay, the one thing I super love about care maps is there's not a lot of rules related to care maps. There's no like Medicare regulation related to them, and so forth. So there's no billing code. So in some ways, it's a freer paradigm for interacting with families than we normally have. And who can draw a care map? Like really anyone. An 8-year-old child could draw a care map, and I've been in situations where they're the ones drawing the care map. So there's no rules about who can, who can't. It can be very formal, informal, spontaneous plan, hand-drawn, computer-based. And I'm going to go through some of these things, and ultimately it'll be up to you what you are interested in using in terms of your own practice or own institution. On the right there, what I'm showing is some versions of care maps. And one is actually of my mother, her care map, and it's on my favorite sort of crab notebook paper that I doodled like a long time ago. And we're going to go through my mother's care map pretty carefully in terms of using the method from Atlas of Caregiving, just to give you some technique and how you can use it. And then the one on the right is actually a very archetypal care map of my own from back in 2010 or 11, I would say. And that the situation for this, we're going to go through this also as a case to show you another way you can deploy care mapping in your own setting. The bottom picture is off of Atlas of Caregiving, their website, as a way of doing caregiving, and I'm going to be using this method today to show you how to care map. Next slide. So another, I just think in terms of thinking, where does care mapping fit into care? And I always come back to sort of like caregiving is a little bit like taking a walk in the forest. Sometimes we do it because we want to be in the forest. We do it because we love the forest. We're happy to be in the forest, but also the forest, it's easy to get lost. It can be dangerous, and sometimes we just need some guidance and some help. And so I see a care map as sort of a trail guide. It's very similar to a trail guide. It's not going to actually walk the walk for a patient, a care map, but it can help them see the way through, is all I can say in this sort of metaphorical sense. Next slide. I just want to tell you a little bit about Atlas of Caregiving. The way I actually just discovered this, I was just perusing the internet and I came across this and I was just like, whoa, wow, this is really great. So I actually contacted them, and I had a great chance to speak to Rajiv Mehta, who is the CEO of what is really a small budget nonprofit that sort of put this together. And my impression speaking to him was simply this was a passion project, and he pulled together a lot of talented people to come up with, I'll say, a toolbox to CareMap. I'll tell you not to go onto the website now, but I left the link, and you can go on there, and it's all for free. And there's a ton of tools that you can use to help facilitate CareMap. I'm going to be going through some of them. If you look, I put the two types of care maps that they have on their website. The example is Christie's care map. Christie is meant to be the caregiver, so a lot of care mapping is for the caregiver themselves to do a care mapping, and that's what you're seeing at the top. And it's very, I would say, it's got this sort of childlike fun element to it, which I really appreciate as an adult, someone who works with adults, because I think pediatricians kind of understand more than adult doctors sometimes how to use sort of visual and kinesthetic and tactile and color and all kinds of ways to capture what's happening with a patient and then apply it to actually utilize it for medical care. We don't do that as well with adult patients. So I feel like this map, the drawing of this map, is sort of getting back to sort of the little bit of the joy and the fun involved in taking care of patients that can sometimes get easily lost and also can be incredibly useful. The one at the bottom, I was discouraged by Rajiv from actually telling you about the one on the bottom. It's actually, they have an online tool to do it. I thought it was really cool, but it's limited. It's limited, and it's not as kind of rich as you'll get with the drawing. So he didn't really want me to sell the online, but I have the link there, and you can decide for yourself whether you like it or not. Next slide. Okay, so why draw one? Why do that? So here's some of the big reasons why it can help. And this came up a lot in the work that I did, is really just helping family understand that they actually are caregivers, because I think many people see themselves as daughters or sons or loyal friends or under obligations, and they don't understand that the role that they have is important, that it's work. You need support for it, and it's a very big commitment of love, but also of stress. And I don't think a lot of people understand this. So care mapping can kind of help people sort of self-explore about their roles, and caregiving is very useful for that. I think it's very good for medical professionals. I wish I could get more medical professionals to actually use care maps to understand care structures. I'm going to get to that, but it's actually hard to get medical professionals to look at care structures, caregiving structures in the first place. Care Atlas calls them ecosystems. I really like that term, so that's another term to apply to care structures. The third one, vehicle for opening up difficult conversations about future caregiving. This is something I did almost daily. I spent probably 60% of my time as a palliative care consultant in the hospital and family meetings, where we would really be working through how are you going to pull off what's going on with this crisis that you're in. So it's a very good vehicle for that. I always think it's good. Care mapping is also, because there's this joyous element to it, to try to say, to reinforce people's good work and to find out what's working for them, instead of just always what we tend to do is we tend to dissect and want to look for problems that people are having so we can fix them, but we don't stop to say, you're doing a great job, and we need to support this thing that you're doing well. And also obviously identifying gaps. And it's a very respectful way to do it. I always say care map should be owned by the patient or the family. We don't own their care map, which is a little different than this kind of way we tend to think about patient information and data this day. We present people with a tsunami of paperwork and sign-offs for their legal sign-offs and how they're going to pay and so forth, and we kind of grab their information and it disappears into the vortex and black hole of the EHR, the medical record, and it feels almost like you're having your information taken away from you a little bit these days and being used for purposes that are beyond your immediate care. So I feel like this brings back some respect in the way we interact with people. It's very relational. Next slide. And then you know, who's served, and I mean, we're talking about people over 65. One of the case I'm going to give is someone younger than 65. It matters not, but it's really helpful when people have serious illness and high caregiver needs to try to sort it all out because it can get very complicated. Anybody who's been working with patients this way knows that you could just have layers and layers of care that can be complex and confusing. So it can be very useful just to map it out. Here are some other populations I think to think about using care mapping is when you suspect someone is in a socially isolated situation and you're just trying to sort out like who who's out there in their world. I think care mapping can be useful for unhoused. I also where people's lives are sort of, collapsing in terms of their social networks. Patients with substance use disorder. And the one I put on the bottom also, which I think really needs to be recognized, is understanding people's caregiving networks in the context of being exposed to issues of climate change. And we're just seeing that more and more where you have elders who are in these very specific caregiver networks, and then you have COVID, you have a hurricane, you have heat, whatever, and those things start to collapse. And that's actually it would happen in my personal caregiver situation, which I'm going to talk about a little bit later. Next slide. I'm going to say care mapping, it's a team sport. It's probably not it's going to be hard to get your doctors to do care mapping. Good for you if you can. But I would say if you can get to a point where someone is doing care mapping, especially, particularly like if you're in a team meeting. If I was back running a hospice unit now, instead of when I was doing it back in 2008 or whenever I was doing 7 or 6. I would be using care maps in my team meetings. It's actually quite an efficient way to work because to understand family structures, and you can unmask a lot of issues very rapidly using this. Once you learn how to read a care map, it's not that different than reading an X-ray or an EKG. Things start to pop out at you, and you can get things done very quickly. So if it was me in a team meeting, I would be using care mapping. Next slide. Okay, so and what settings? It's really any setting. I have a big experience using them in family meetings, and then also I've used them many, many times to talk to families and patients really in hospital settings and in hospice settings, just to sort out what's going on. The other cool thing I think they could be really taught in workshops to caregivers. I think it would be fun and useful to use in a family caregiver workshop if you're doing one in your group. And actually, I think Atlas of Caregiving has some workshop model to look into. And then also the other thing I think would be super useful, and I wish I had had this when I was in the midst of a big caregiving thing, was to have home health aide training around care mapping, because paid home health aides are often kind of in a web of family caregiving that they're in, and it can be very difficult for them to sort that out and develop strategies for how to deal with families. And I think using care mapping as part of training would be incredibly helpful for that group as well. Next slide. Okay, so we're gonna start doing some cases. What I wrote here is how this is a case actually it's around 2011, I would say. And it was really, the reason I have this case up here is because it was really when I started understanding caregiving infrastructure as absolutely critical to the work that I do as a palliative care doctor, and really taking care of any older person. And then also part of this journey of convincing other doctors to understand family structure as actual medical care. So this patient is a 42-year-old man who presents to an emergency department with severe rectal bleeding and pain. And then he had some imaging which showed a lot of tumors, and he had a suspicion of colorectal cancer. When I was called to see this patient in the emergency department, mainly to deal with pain, because I worked a lot with pain, particularly with oncology patients. And I went down to see this patient, saying, we need your help, immediately to help him with his pain. Next slide. So what you see here is this is actually from the pre-EHR. This is sort of the way we had to chart in the medical record back then at Stony Brook. And I was actually using this as scrap paper. But what happened here, if you look on the right there, you can see he was getting a lot of what we call pushes of Dilaudid. It's a very heavy pain medicine. He was often getting 2 milligrams of Dilaudid, which is like 40 milligrams of oral morphine, which is like basically taking a scoop of Percocet and putting them in your mouth. It's a lot of drug. So he was in a lot of pain, and I spent several hours getting his pain under control. But then once I started to talk to him, that's when I started to really get sort of the knot in my stomach in terms of dealing with this patient's life. And it's very blurry what's on here, but I'll just sort of give you a short history. Is essentially he had moved to Long Island. He was living with a partner who he had a 7-month-old child. Very recently, he was divorced. His ex-wife was living in California with his 2 teenage daughters, and then she had a drowning. She drowned and died, and then he found himself with his 2 teenage daughters moving in with him in Long Island. So they hadn't before this all happened with him. He had just had his daughters move in with him, and then he had a 7-month-old with his new partner, and then somewhere in there he lost his job, so he was uninsured. He was ignoring rectal bleeding for months and months and months. It was going on, and then he landed in the emergency room, and that's when I saw him. So, as this sort of diagramming I'm doing sort of crudely is really sort of what I was actually doing for efficiency. I was doing it as an efficiently to get down some information about him, but really it's an early form of just care mapping and trying to understand this patient's care structure. New slide. Okay. So this is actually Atlas of Care's approach to care mapping, and I didn't obviously do this back then. Their approach back then, I might have done more like boxes and circles and then names and things like that. But the way that this is a very helpful thing for you to use in your clinical practice and to do quickly is simply to help a patient and a family understand what's going on with a very complex care situation. And in this particular situation, this was someone who is literally getting a tsunami of medical care, like all at once. So if you look at this map, the way it's set up is you have the house and you have the patient with his family in it. And then the arrows represent the care, and how thick the arrow is basically is how much care is being delivered to them. And in this particular diagram up on the top, you have this pack of consultants related to his cancer. And first and foremost was the colorectal surgeon, because he was about to go for a resection of masses. He was a pre-op. So this person was very fundamental right now for his care. And then he had this pack of consultants that he saw along with their teams, the medical oncologist, the radiation oncologist, the gastro. So he had this whole team there. Then underneath that, he was actually on a hospital's team. He had a PCA being managed by them, a patient-controlled analgesic pump that I was prescribing for, but they were involved. We have a pile of nurses and nurses' aides that were dealing with pain and rectal bleeding, all giving what I'll say emotional support and caregiving to this patient. Then you had the whole separate team of me, palliative care, coming into the situation. I was trying to manage this pain. I was trying to also, what I did here was this patient was unfortunately also in arrears for childcare, even though his ex-wife had died. California hadn't caught up to that. So he needed a ton of legal work related to his children, and I got a public interest attorney to come into this situation. We had the social worker pair up with the attorney to try to sort of sort out his insurance, get him insurance. He needed proxy, he needed healthcare proxy, power of attorney. He needed so much behind the scenes that we were trying to mediate. And then also he was, I want to say Italian Catholic, so we had our chaplain meeting with the family. And then you see these big circles that you could make. It sort of says the involvement, and I put this middle circle around all of this because these were the people really giving the frontline care, and then the circle around it are the people that had seen him but weren't really involved yet. And then you had the mother who had died out there, in heaven. But that person, in terms of counseling and the things we were thinking about for those girls that he had, it was huge at the time to try to help them sort. There was a lot going on emotionally for this family, and this was all coming at this patient. So the way I use the care map is I literally would sit with him at the bedside and we drew this out, not this particular care map, we drew it out. And when I would come see him, we would refer to this care map. And the thing about care mapping that is very good, what I like, is simply he owned this care map. I left it with him. I didn't take it with me. I didn't scan it into the EHR. And, so it was his. And they got in the family would literally take out the map when I would come in, and we would go over it, we would revise it if they had questions, and it just helped them sort it out. And this is obviously for a medical crisis, where, the way I'm going to also show you is how to use it in the outpatient, but it's super helpful to understand care that someone's getting. And then also I could have had him draw this map also and not input it, just to see what he understands. So it's actually a good way, if you think people are very confused, just to see what they can draw out themselves. I think using stick figures is actually a pretty non-threatening kind of way to do this that everyone knows how to do. So I wouldn't hesitate to use it, actually, using the stick figures. Okay, so I'm going to go on. And I put this picture up here. This is this family that I'm talking about right now. And the patient gave me this picture in long time ago in 2011. And the reason he gave it to me was simply because he really wanted to be part of teaching, and he knew I would be using this as a teaching tool. And he loved that idea. And so he gave me this picture. I have since, because I've gotten sort of so worried about the internet and sharing on the internet, I put this black line, these creepy black lines over their eyes, which is new, just to try to deal with the fact that we're doing this talk on the internet and so forth. But the picture's there just to sort of put a face to all this, to say thank you to this patient who, unfortunately, I took care of for about 2 years and unfortunately died of his cancer. But yeah, so next slide. Okay, now I'm going to talk about care mapping in a different way now. And this is really more how you might use it in an outpatient setting. And it's, I'm actually, this is my mother. I will, spoiler alert, it's my mother. But I'm going to first tell you this story from the perspective of how you might see in the EHR. So I'm just going to read this quickly. Mom, she's 90 years old. She has a history of dementia. She has high blood pressure. She has reflux disease. And then she also has a history of multiple falls. And then she presents to an emergency room with severe wrist pain after falling off the toilet. And she basically broke her wrist. And then what happened, if you look down the review of systems, and this is a true story, if you look at the review of systems, which is a typical thing you might see in a chart related to a fall, is that she didn't pass out, she wasn't dizzy, and there wasn't any other thing they noted. And the other thing I put at the bottom, which I just want you to recognize, is how little charts have about social history, because most of them, social history in most EHRs now are really there as a billing mechanism, mainly for billers, and it doesn't at all convey the richness of somebody's social history whatsoever. You basically put in these check boxes about tobacco and no substance use, although I have a little reveal about the substance use with my mother, but we'll get into it later. And then it says she lives alone, which of course doesn't tell you anything, and she has 3 children and she's widowed. So that's the typical thing you might see in an EHR. Let's go to the next slide. Okay, so this is actually from Atlas of Caregiving, and I like it a lot. And you can print this down and print it, and then use it in your own practice if you choose. But really, it's just to collect some data for a patient to do, a caregiver themselves to do on their own. And I like it for a couple of reasons. One, because there's a lot of space, and it's not very prescriptive, because we tend to have check boxes and a lot of that for our patient care these days. So what it does is it has my name at the top. It's got who lives with you. Okay, my husband and my dog. And then it says who cares or supports me, the caregiver, Lynn. And then I can put who I want in that box. And I put like my husband's daughter, son, dog, friends, and then some work colleagues actually for me were actually a really big part of my support network for my mother. And then if you go down, it says, who do you care for? And you can put more than one person in there. But I put my mother, and I put she lives alone. I added in that she has a weekend boyfriend, age 92. And then if you look down, it says, who else cares for this person? And then we had like a posse of paid home health aides, about 5 or 6 people. And then I have my sister, number 2. This is my older sister. I'm the youngest in my family. I have 2 sisters. And I put the yellow line because those are the people that really, really were frontline for my mother's caregiving. So I think this is, even if you never do anything else and you don't do the care map, this in itself is a useful thing to use with patients and families. Next slide. Okay, so here's 2 versions of a care map. Like the one on the left, which I showed you a little bit before, is a doodle that I did of my mother's caregiving situation quite a while ago, actually. You know, this is the way I would do it. And when I did this, I was partially doing it for myself, but I was doing it from the perspective of being a doctor daughter. So a lot of the information that you see on there is information I thought as a doctor other providers would want to know. So that's the way I did my mother's caregiving map. And just to do it go through it very quickly, up on the left, you can see that there's weekend boyfriend. And the thing that I noted about him was that he used to drive my mother, which is a whole thing, okay? But he was driving my mother. Then there was daughter number 2 over to the right. Daughter number 2, which is daughter number 1, she lives in Massachusetts. She wasn't incredibly involved with the frontline care. Then you have 3 on the right, which is daughter number 2, which is my middle sister. She lives in New Hampshire, and the thing that I wrote down there was that she used to travel down to see my mother regularly, like 5-hour drive. And what she was doing was she was in charge of managing all the nitty gritty of the home health aides, because we were doing what a lot of people can't do. We had professional home care, we were doing self-pay. And she was managing that. It was a huge job. And she was her power of attorney for finances. Then if you go down a little more, there's daughter 3, that's me. I was the one who lived closest, but I actually lived an hour and a half away. And I was my mom's healthcare proxy. And then, I'm the doctor daughter. And then over on the other side, the left 5, you have the professional home health aides, which were with my mother at this point when I did this map, Monday through Friday, because the weekend boyfriend was actually serving as a caregiver at that time, and they were private hire. So that's kind of a version of it doesn't take long to do this, but it can tell you if someone does this as a provider, you could just learn tons about somebody's situation just by looking at this and what they need. Over in the right there, because I thought it was cool, I did the online version, and you can see it's a little colder in terms of, and if you really want to know anything, you're gonna have to dig and find out what all the little circles and all this stuff means to go into this. So Atlas of Caregiving, Rajiv, he doesn't like this method. He didn't want me to recommend it to you, but I think it's cool. And that's my mom's, just looking at it. So you can decide for yourself. You can click on the link later and do that. Next slide. Okay, ta-da! So this is my mom's, drawn care map. And I actually did this last week because I didn't do this. I wish I had done this version of it when I had my mom. My mom died in 2020. But I actually still smile, and it was actually still, I would say, therapeutic for me even now to kind of do this map. And what it does is it just brings to life our whole network. And I think, when you do a map like this, unlike the one I showed you before for the patient in the hospital that I was really trying to help him understand his care, this map, when you do a map like this, it's first and foremost for the person doing the map. Okay, so it's to help them understand their situation. If you choose to do this with a patient or family, I think the kind of relationship building and rapport and humor and joy that you can inject can be huge to do something, a drawing care map with someone. So I recommend it from that perspective. So the things that's different about the other ones I showed, you see my mom in the middle there, and those orange arrows that I drew, that's because my mom was really a matriarch in our family, and she was a massive caregiver herself. She herself was a loving caregiver, and I just wanted to acknowledge that in this care map. If you go to the top there, I put my father, my father in heaven, who died in 2004. And the reason I put him here is because he supplied like this enormous pile of money, as I put there, to support the out-of-pocket self-pay that we were doing for caregiving for my mother, which, you know, we were very, very lucky and privileged to have. Most people do not have this. And this is the elephant in the room in a lot of these caregiving situations. It's a whole nother webinar. I'm not going to get into it about payment, but it's something that can be very stressful. Even people they're afraid to bring it up. They think they don't want to talk about finances. And it can be this huge thing. People don't realize that there's really no payment structure for caregiving other than Medicaid and what that really looks like. So I put my father up there to acknowledge the pile of money that we spent down over about a 10-year period to take care of my mother. There's me on the right in my house with my little caregiving structure and my blue arrow pointing towards my mother. On the left, you have my sister in New Hampshire with her blue arrow towards my mother. And then the thing to notice there, which also is that she has a blue arrow down to the home health aides. And then there's a big, thick blue arrow going from the main home health aide to my mother, because in reality, we had these people, we were so lucky, who were really with my mother all the time. And they were the ones that actually allowed my mother to live the life that she wanted to live, because she had access to professional home health aides that kept her going, and we were able to finance and support it. So this an unusual situation. It's a lucky situation, I would say. Then you have on the bottom right, you have the joy factor of all the grandchildren, and then these other kinds of supports and so forth. But yeah, so this is the map of my mother, and what I would say to you is to consider doing these maps with families. Or the other way, to do this is you could give them an example. You could give people an example of a map like this, like from Atlas of Caregiving. And they'll figure it out. They'll do their own map, and you can discuss it with them, have it bring it in. But if you train people to see their caregiving in these bigger pictures, it's a very good way to sort of unmask what's happening with them that sometimes we don't pay attention to, or we just overlook. We keep it invisible. Next slide. Okay, so this is for all the sharp cookies in the audience, as I like to say. So I put my mom's care map on the left there, and then I put her history on the right. And what I'm asking people, if they're feeling brave, is to put, how do you connect up these two things? How do you connect this EHR history with my mom's care map that actually turn into medical care? Because to me, that's the key thing. As a professional, how can I look at a care map like this and help, make things happen, for them? And because care maps can function in a lot of ways, but I just want to look at through this lens of how you can look at it from a medical professional way. So I'm just going to read while you guys think. I'm going to give you some hints, but my mom's 90 and she has dementia, high blood pressure, GERD. And then, dun, 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 she has a history of multiple falls. And I'll blow up that history a little bit just to tell you. She fell once, slipped on ice outside, picking up a newspaper, broke her hip. She slipped off a toilet in Howard Johnson's and got wedged between the wall and the toilet and dislocated her arm. She broke her wrist. And then there was another big fall, which I'll tell you about later. So there's falls. So, what does that tell you? What do these histories tell you when you look at the map? Like, what would you want to do in this situation? Did anybody put anything in the chat? I don't know. Let me look. I don't see anything. That's okay if you don't. Someone's wrote, I see, ooh, I see. Yes, yes, yes. Home health aid, walker, ability to sit and stand. Lots of what I'm seeing here actually is really what was, I'll tell you, is the missing link in the care that we had for my mother is we didn't really have anybody, when my mother went into, my mother had, yes, someone said, I want to make sure the home health aides were aware. A lot of things I'm seeing a lot of, yes, OT evaluation. So, right, yes, 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 and yes. So let me just say that in our case, my mom had her wrist casted, and basically what happened was, very good point, osteoporosis. My mother had really bad osteoporosis. Okay, so I'm going to click off the chat, so I'm not going to respond to any more of them at the moment, but I can say she had her wrist casted, and really what that meant was that she couldn't use her right arm to walk. She spent a lot more time in a chair. It actually reduced her mobility because she couldn't leverage to get up because she was casted for like 6 weeks. I think it resulted in some muscle wasting. All those things together made my mother more frail, like a whole lot more frail. I remember worrying about it at the time of the break. I thought her wrist fracture was literally going to kill her. She was like 91 or whatever because of these other what we call snowballing problems that was happening, frailty. But we really didn't have any. If I had had a care map and then I had someone, a social worker, we had no access to a social worker or somebody. The primary care doctor we had, wonderful, but she was basically filling her meds and taking her blood pressure and getting labs. Like we didn't really have anybody helping us. But what we really needed at that time was we needed a home safety evaluation, a really intense one that we needed training of the home health aides. We needed home health to help us train aides about safety for walking and so forth. We really need someone to dig into her meds to see if she was having balance problems. She actually had a cataract that we had to make a decision about whether she needed an operation for that. And like the big reveal is that before my mother fell, she had actually gone out to lunch with some friends and she like insisted that she have an alcoholic drink. And because I wasn't there to say no, she had an alcoholic drink and she was a little tipsy when she left. And so that's when she fell. And no one asked her about alcohol in the ER. No, because they just assumed there's some, ageism issues about, okay, she doesn't drink, whatever. And it was only one drink. And for her, the one drink was enough. So we really needed some strategies about how to deal with all of these things that we weren't getting at the time. But a care map can really be sort of a lever and a vehicle to kind of make these identifications quickly, and also to harness, get your doctors to prescribe, to recognize, and to pull things together for families. So I think it's just a tool to use. Next slide. Okay, so these I think are actually really good also, and I wanted to bring them up, and then I wanted to leave a few minutes at the end for questions as well. But this is from reflection questions. I think they're excellent. I really do. They're from Atlas of Caregiving. I wish I would use them if it was me. And it's asking who's indispensable, and it's really to give. The questions are meant to give to a caregiver and have them think about it themselves. Because sometimes what happens is we tend to pepper people with a lot of questions because we have agendas about what we think they need. And we don't ever give them the space to kind of figure it out for themselves and to figure out what they need, sort of using reflection to do it. So care mapping is really a form of reflection for a patient. And then these questions, once they've done a map, say, well, what happens if someone's not available? And not to accuse them of that, but just give them the questions so they can think about it on their own or with other family members. It's very helpful to do that. And are people aware, is everybody in your care ecosystem aware of what everybody else does? Because we had problems with that in mine. We had to really sort out, we had very specific roles in mind, but it took a couple of years to kind of get that all communicated pretty well and settled. And then what actually skills are being given? Is it transportation, companionship, laughter, comfort? What are people doing? And then how are the responsibilities divided? How is it communicated? A lot of things. Who is being overlooked? And it's funny when I think Rajiv pointed out to me, which I thought was interesting, when most people draw care maps in his world, when he's done workshops, people don't draw their medical teams. They're not in the care map at all. Like I did the one with the medical team, and I didn't even in mind put the medical team. I forgot about them. And that happens all the time. So you have to kind of see where it's not recognized as all that important to families, the medical teams, when it comes to caregiving. I'm making a generalization, but they don't put them in their care maps. Next slide. Then this is where things can get very helpful. Are there professionals or services missing, and what's needed? So if you learn how to read a map, well, you're going to start seeing where the holes are. Like in mine, you can see there's just enormous amounts of people involved, and my mother had fall after fall after fall, and to try to address that, and you can see that come out in our map. And then maps are living. I'll call it a living document. They're not meant to be static. So they're meant to change over time. So I think a very legitimate question is, what would you imagine a care map looking like, in 5 years or 1 year, and what do you envision happening? And that gets into planning for care for the future. I did a lot of this. I did a lot of this kind of mapping with people, like, what are you envisioning? Let's go through that. And the other thing I think is important to say, which we tend to forget, is what's actually working. And what would you not want to change? We don't tend to phrase it that way. We tend to look for holes and problems and to fix things. We want to be fixers for our patients right away. And we don't ever give them the space or the acknowledgement for the things that are actually working really well for them. And what I call the heroic journey of caregiving. So that's just to say what's working, So these are all great questions. Next. Okay, I'm just going to show you just a couple of other very quick other types of care mapping. One is called photo mapping, and that's me and my mom. She's probably like 89 or something there. And then at the bottom, I'm going to show you something called word clouds, which also is another simple way to care map, which I highly recommend. So I'm just going to show you those. Okay, so I used to use pictures a ton in family meetings to kind of help families go the journey of serious illness and what's happening to people when they have a serious illness and they're aging. So I would have them show them on their phone, or I'd have them print them out, whatever. You can just get photos. And oftentimes what I would say is, can you show me a picture? Show me a picture of your dad when he was really himself at his best, when he was living his life to the fullest. When was that? And was that 5 years ago, 2 years ago, 10 years ago? And bring that picture up and look at that picture. And then I would sort of go down the journey of pictures with them. Tell me, when was the first time things really changed? And people might show me a picture of a wedding where the person's now has a walker. Or, and so we sort of move closer and closer to the situation that they're in now. And it's a very useful way at getting families to kind of step out of the forest and kind of see trajectory of illness. So I used to use photos all the time. It's easy too. You don't have to have a lot of tools for that. This is my mom and her boyfriend, and this is her 90th. And I'm just sort of going to say, what does anybody see anything that they want to comment on in this picture? Just quickly, do you see it? If you don't, that's okay, because it's a little hard. But he had actually for years, this gentleman, yes, definitely that. Yes. But I'm going to bring up something else here, is that he was serving as a caregiver for a lot of years. But then, I don't know if people noticed, but he has a very swollen hand in the front there. He has, at this point in his picture, there's some very serious heart failure going on. And, he was, he was at end of life too. I mean, he was 92 at this point. And yeah, so we had a lot going on behind the scenes trying to make these shifts with my mother, because this person was so special and so important, and also a family caregiver. So there was a lot going on, but we also had to shift caregiving. And also we had a situation where we had a hired caregiver now on the weekends, but they were doing caregiving for two seniors, as I'll say, super seniors, um, but being paid for one. So it got, we had to, there was a lot to figure out, a lot to work out, it got very complex. So you can use pictures very effectively for that. I'm just going to show you one more picture of my mom, and then we're going to stop, I think. This one, just to show you, things can change. There's a lot going on. I could probably spend 30 minutes on just on this picture. I put a link to I actually wrote a article about what it was like to caregive for my mother during COVID and what happened to us. And that's in JAMA, and it's you can get it for free if you're interested in the story. But she actually fell again, and she actually broke a bone in her neck and spiraled into end of life. And probably this picture is maybe 6 weeks before she died, 6 or 8 weeks. Um, and there's a lot to analyze, but if you're trying, you could see that we have two aides here, not just one, because she couldn't lift her, she was incontinent, she had a neck fracture, a nose fracture, a rib fracture, she had trouble swallowing because of the neck brace, on and on and on and on. So I think just looking at this picture, you can glean a lot of what needs to be done here. We needed a lot of assistance. We had an agency at this point. COVID was going on at the time. So as a provider, there's a lot to see in this picture in terms of offering assistance. Next picture. Okay, and this is just a word cloud, and I gave it the link at the bottom of the slide. It's just fun, and if you're stressed out at work, or if you're trying to figure out your own caregiving, I highly recommend that you do a word cloud. Or if you're not getting anywhere with the family or a patient and you have them just put down words and put it in a word cloud for them, it actually can be quite joyful and therapeutic to do it. So I just put that out there for you. So I'm going to stop so we can just have a couple of minutes. If people have questions about all this, and we're going to tell you about, we're going to also tell you about some upcoming events that I'm going to let Ariel step in and tell you about. And if Ariel, if you've noticed anybody had a question over the course of the video that you want to bring to my attention.
Sure. Yeah, no, we had a lot of great comments and responses to some of the pictures. I haven't seen a question that's gone unanswered yet, but certainly we have a few minutes if anyone wants to put something in the chat or the Q&A feature. And yes, like Dr. Holloman mentioned, we are going to be able to take a deeper dive in a learning collaborative starting in just about a month. So October 13th, Dr. Holloman is leading a learning collaborative, so 4 sessions around partnering with family caregivers. So we'll be able to, in at least a few of the sessions, utilize some care mapping techniques, but also talk about those person-centered strategies for building trust and communication. And really, again, just taking a deeper dive into this topic. Learning collaboratives are primarily focused on health centers and lookalike locations. So feel free to sign up for that if you're interested. I know that Juliet will put that in the chat box. I see a question around to review this video. Yes, we will send out a link to the recording when it's available, or a link to our YouTube page. We do like to get these recordings closed captioned, so we send that off for closed captioning right away, but we will send you the slides right after this session closes. And yes, thank you all for putting the links in the chat. We'd love to see you at this learning collaborative, and we certainly will have other activities going forward on a variety of topics related to older adult health. Let's see, one question.
Can I make a comment, Ariel? I just wanted to say that with the collaborative, I'm probably going to try to do, we haven't totally worked this out yet, but I would really like to use care mapping as a tool to facilitate family meetings and communication, because I have a lot of experience doing care mapping that way. And so I want to take a very deep dive into how to run a family meeting using caregiving. So if you're interested in that, we're probably going to do that.
Sure. I know we're just about at the end of time. There's a question around using care mapping with working with other demographics, I will just say yes, there's definitely lots of different groups of people that this technique can be used with, especially in pediatrics. So we're really talking about the two ends of the age spectrum, but there's a couple of other comments I don't know if we'll fully be able to get to today. But we have a question around using it in larger groups of older adults to understand the collective experience, which that's a really interesting question, Laura. We also have a question on release of information process. So talking to anyone based on what the participant is sharing in their care map. So I think that there's a lot there that we might not be able to get to today, but for those who want to stay for one more minute, is there something succinctly, Dr. Hallerman, you want to mention to either?
I'm not sure I can answer that in one sentence.
Yeah, it's tricky. It's tricky, but I do think those are good questions. I do think primarily if this is meant to be an individual interaction, one-to-one with someone, in this case, a clinical setting with an older patient. So I don't know if it's been used a lot in collective settings, but I think that's an interesting idea to put the general ask out there for folks to take a care map and do that for themselves when they're doing it in a group setting. And then certainly, there's a lot more that can be explored there as far as how to use information in a care map. But I think first and foremost, the patient using it for themselves is what's really helpful. But we will email the slides to you, to the question in the Q&A box. So I know we're over our time, but thank you so much. We will, again, dive into these questions even more in our Learning Collaborative. So we'd love to see you there. Thank you so much, everyone, and have a wonderful rest of your day. Take care.
Bye, everybody.